So next week, like I said, we have a quiz. It's over this week's material, okay? And also next week, I'll do an exam review, and the other professors will have their exam review for exam 3, because then it's that following week, that following Monday. Okay. All right. Are you guys able to see my PowerPoint here? Yep. Okay, perfect. So like I said, we'll start with the child with the condition of the blood. So blood and lymphatic system, okay, is what we're starting with. Your objectives are right there. Know them. Know all of the things on this page. This will help kind of guide your reading, okay? I'm not going to read them all to you, but refer back. It's under the week 7 information slide, okay? So the lymphatic system, this is responsible for your immune response. It also is responsible for draining, toxic kind of things from the body. Your tonsils and adenoids are involved in your lymphatic system, your thymus gland, which is very important in newborns, and it kind of shrinks in size and doesn't continue to be utilized into adulthood, but it's very important for newborns. Your spleen is also involved in your lymphatic system, okay? And then, of course, your lymph nodes, which do the filtering, okay? So this is where those infectious kind of organs, or those infectious organisms, start to be broken down, and the antibody production is started, okay? Lymphadenopathy, which is the enlargement of lymph nodes, that's just kind of a sign that that lymphatic system is fighting off an infection and creating an immune response. Okay. You most commonly, out of all of these organs, you most commonly see the spleen becoming the most enlarged organ within the lymphatic system. It's also the largest organ within the lymphatic system to begin with, okay? So it brings the blood into contact with those lymphocytes. So the lymphocytes are a white blood cell, okay? That's a part of fighting off infections or disease, okay? Like I said, our lymph nodes likely will enlarge during infections. If there's anemias or liver or spleen malfunction, then a lot of times you'll see those lymph nodes becoming more enlarged. You can also, of course, see lymph node enlargement with like cancers, okay? So if parents are calling about their kiddos with multiple big lymph nodes in different spots, so, neck lymph nodes, armpit lymph nodes, groin, inguinal lymph nodes, then you would get concerned that there's something going on, potentially a cancer, okay? So circulating blood, it consists of 2 portions, so plasma and then the formed elements. So the formed elements are probably what we most commonly think of, which are our red blood cells or erythrocytes, okay? Red blood cells, erythrocytes, same thing. So these work to transport oxygen and carbon dioxide to and from the lungs to the tissues. That's the purpose of the red blood cell or erythrocyte. Leukocytes are white blood cells. This is your defense against infection. And you can see here are your leukocytes. There's different types of white blood cells, okay? Like I said, the lymphocytes are what's produced in your lymphoid tissues. So in those lymph node areas, okay? And thrombocytes are platelets, and those are produced in the bone marrow, okay? Okay, anemia. So this can result from a lot of different underlying causes. There's a bunch of different anemias classifications, okay? What are common signs of anemias?
Fatigue.
Yep.
Cold,
Cold. Yeah.
eating ice chips.
Yep. That's specific to iron deficiency anemia. Yep. Or wanting to eat like non-food like things. Pica. What else? Pale, right? Their color isn't going to be as good. They might be short of breath. If they have significant anemia, they may also progress to congestive heart failure if their anemia continues to not be well managed. Okay. So really important to figure out if people have anemia, what's the cause and how we can correct it. So anemia is essentially a reduction of the circulating hemoglobin that then reduces the oxygen that's being carried by the blood on the erythrocytes. Okay. So hemoglobin below 8 results in increased cardiac output and shunting of the blood from the periphery, so from like the hands, the feet, the far out spots, to the organs, to the vital organs. Okay, that's where you see people who have anemia have, like you said, Marquetta, the cold, cold hands, cold sensation. Okay. And the way anemias are classified, it's based on like the size of the red blood cell or the shape of the red blood cell. That's kind of how they look at classification for anemia. Most common in kiddos is iron deficiency anemia. We kind of talked about this a little bit during our infant/toddler weeks. It's most common because of nutrition. They're not taking in a lot of iron-rich foods. They're also a lot of times consuming a lot of whole milk, which can worsen their iron deficiency anemia. Okay. Typically seen most at risk between the 9th and 24th month. And then the risk kind of goes away for iron deficiency anemia, and then it comes back around adolescence. Why do you think it comes back around adolescence?
Growth spurts.
Growth spurts, yeah. Yep, definitely a part of it. And they're probably not eating super healthily once again in adolescence. You can't really control as much of what your adolescents are eating, unfortunately, like you can with the school age kids. Okay. So manifestations of iron deficiency anemia are going to be very similar to those with any anemia. So they're going to be pale. They might be more irritable. They may have anorexia, so they may feel like they're just not hungry. Okay. And they might have a decrease in their overall activity because they're fatigued. Infants with iron deficiency anemia, if they're drinking a lot of whole milk, so I would say toddlers, so like a year and up, when they're chugging whole milk, and that's mostly what they're living off of, some kids, they're going to tend to be more overweight. So that sometimes can be a sign of iron deficiency anemia as well. Okay. That increased age range is because, yes, they're having more rapid growth. They're relying on, their prenatal stores of iron from their mama are wearing off. And so then they're switching from iron fortified foods or formulas to, whole milk, which depletes their iron further. So tests to do to identify iron deficiency anemia, those obviously include blood tests. So your red blood cell count, which is within your CBC. Looking at your CBC totally is really helpful because then you can see those morphologic cell changes. So the shapes, the sizes, the frequency of those red blood cells is also what's looked at. That can kind of give you a picture of whether it's iron deficiency anemia or another form of anemia. You can also look at a blood study of their iron concentration. So You can look at a ferritin level or a total iron binding capacity or just a straight up iron level. Okay. So there's a few different studies that you can do related to the iron blood testing. You may also want to check the stool for blood because people who have iron deficiency are also more at risk for GI bleeds. Okay. So if you continue to not treat iron deficiency, then like I said, things will slowly progress. So the heart muscle may become too weak to function. Kids are going to have growth retardation and cognitive changes. So like they're not going to, be as tall as they should be. They're not going to weigh as much as they should be. They're going to maybe not cognitively have as much function as they should if they continue to have low iron and it's not corrected. Treatment is ferrous sulfate. Typically, there's also ferrous gluconate, which you'll see. Not that that's one to avoid. It's just more common that we use the ferrous sulfate in kids. Usually they're doing that 2 to 3 times a day, and they have to take it with vitamin C to absorb it appropriately. Okay. Also something to teach parents, if their kiddo's on iron, they're likely going to have kind of gross, dark green, tarry stools. Okay. So parents might call you, hey, I just started my kiddo on iron and now their stool is really dark green. Is that okay? Or is that something I should be concerned about? Okay. Do not give iron with milk. Okay. That's a big thing, but orange juice or something like that is most beneficial. Okay, critical thinking question. Okay, during a routine child clinic visit, the nurse notes that an 18-month-old has pale skin, appears lethargic, and is overweight. The mother says the child is becoming less active and increasingly irritable. What should the nurse suspect is the condition, and what's the appropriate education? So first, what's going on with this kiddo, do we think?
Anemia.
What kind of anemia do you think?
Um,
Look at the age.
Oh, iron deficiency.
Iron.
Iron. They're tired and they're overweight.
Yep. And they're 18 months, right? So they're right in that prime age group between 9 months to 24, where it's most likely to be iron deficiency. Okay. So what would you educate those parents?
To increase their iron in their diet.
Yep.
And to give them vitamin C with it.
Yep. So ideally, you have those kiddos cut back on milk, right? Whole milk, because that worsens iron deficiency. And you also, yes, increase the iron in their diet in the form of food. That's the best way. So broccoli, green leafy vegetables, meats, red meat specifically. Now that's kind of hard to do with 18-month-olds because they're already pretty picky. So the other way then is to then supplement them with iron. Okay. Ferrous sulfate. How or what would you do to confirm that it's iron deficiency? And not another anemia? What test?
To the CBC.
CBC. Yep. Good. All right. So sickle cell disease, and you can see in this picture here, this is the sickle cell. So this is the red blood cell that's sickled. You can see there's quite a few of them. A normal red blood cell should be nice and circular, look like a perfect little donut almost. But in sickle cell disease, it's going to be more sickled shape. Okay, so you can see there's quite a few of them. So sickle cell, there's different kinds. So you can have sickle cell trait or you can have sickle cell anemia. Sickle cell trait is asymptomatic, okay? So they do not have the sickle cell crisis, okay? So they'll have a mixture of normal red blood cells and sickled red blood cells, but a very low number of sickled cells, okay? And actually, when you get a CBC, you can see the difference under the microscope when they're looking at that, okay? So the child only got one copy of sickle cell trait from one parent, okay? So that's trait. They only got one gene for sickle cell from one parent. So they don't have full-blown sickle cell anemia, okay? Sickle cell anemia, you'll see that start after about 6 months of age. Has to be inherited from both parents, okay? These kids are going to have a higher number of sickle cells. So they're going to have, you know, potentially more sickled cells than healthy cells. Okay. This is caused because the bone marrow starts to impair the circulation with those sickled cells. Because of their shape, they're more likely to clump together instead of flowing smoothly through your vascular system. When they clump together, that's when you have an occlusion of the vessel, and that's when you see sickle cell crisis happen. Okay, that's where that pain comes from, is when they have that occlusion of the vessel from those sickle cells. Okay. Eventually, if that clump or that clot from those sickled cells isn't resolved, then you will see kids have ischemia of those organs or those vessels, wherever that clumping has occurred. Okay. Kids with sickle cell disease, they're going to have lower hemoglobins than typical. Okay, so they're going to be in the 6 to 9 range and be not super symptomatic. So they're not going to be really pale. Usually they're not going to have a lot of kind of the classic anemia side effects. Okay. But if they're getting lower than kind of their low normal range, then that's when you're going to see them start to have those anemic kind of symptoms. So the paleness, the fatigue, little appetite. Okay. Sickle cell crisis, they're very painful. They can be fatal, right? Depending on where that clumping is going. If that clumping is happening, you know, in a major vessel, then that's going to include a lot of oxygen and things going to the brain. Then that can obviously be fatal. So symptoms of a sickle cell crisis are severe abdominal pain. These kids have significant severe pain. Most often they're always on a PCA pump, okay, for pain management when they're hospitalized with sickle cell crisis. The other thing to do in kids who come in with sickle cell crisis is you want to make sure that they're very hydrated. So they're going to be getting fluids and they're going to be having pain management. That's going to be the most common things that you're doing with kids who come in with sickle cell crisis. Okay. Kids with sickle cell are also at an increased risk for stroke. Okay. Which makes sense because of those cells and the abnormal shape. Okay. Okay. So there's types of sickle cell crises. So vaso-occlusive. So that's when that clumping happens and there's an obstruction. Okay, this is the most painful crises. Splenic sequestration. So that's going to be the pooling of the blood in the liver and the spleen, causing the spleen to become very large because of that occlusion. Okay. This, as the spleen becomes larger and that blood's pooling in the spleen and the liver, it eventually leads to circulatory collapse and shock. Okay. Aplastic crises. So this is when the bone marrow stops producing red blood cells. Okay. And hyperhemolytic means there's an increased rate of the breakdown of the blood cells, the red blood cells. This may be because of infection or because of poor splenic function due to fibrosis of the spleen. Okay. So there's different triggers. Obviously, based on the triggers or kind of the cause, you can try to figure out the type of crises that they're going to be in. So decreased oxygen levels. So if these kids are running around really, really active, they're short of breath because they're so active, you know, they're getting to the point where they could potentially have a crisis go on. Dehydration, because they don't have a good amount of fluid circulating with their blood cells, because dehydration, then you know it's going to be more likely that you see that clumping occur. Infections, just because that's the strain on the body's function. That's another potential cause. Physical or emotional stress on the body. So like I said, running around, being really active in sports, things like that can definitely cause a sickle cell crisis to occur. And exposure to cold. That's another form of potential for sickle cell crises. Okay. So all of those things can trigger those different sickle cell crises. So you don't want to keep sickle cell kids in a bubble, right? Because we want to have them have somewhat normal lives and be able to, you know, play sports and things with other kids. So the biggest thing, what do you think the biggest thing you would talk with parents about making sure that they're doing if they're going to be in sports?
Drinking a lot of water.
Yes, staying hydrated. That's going to be the biggest thing. Okay. Okay, CJ Sim. Okay, so we'll kind of use this as like a critical thinking type question. So Raymond is a 16-year-old who's admitted to the adolescent unit with presenting fever, joint pain in his knees, shortness of breath with exertion, and fatigue. He told me he is stressed out and not sleeping well. He's diagnosed with sickle cell anemia at 9 months of age. His parents are extremely vigilant in his care. He's only been hospitalized 3 times since his diagnosis, which is amazing. Once at 9 months when he was diagnosed, 5 years of age when he had a thrombotic occlusive crisis from pneumonia, and a third hospitalization when he was 13 for IV and oral chelation therapy. Throughout his school age years, he was treated with penicillin prophylaxis. That's another thing with kids with sickle cell. It's because you're concerned about infection worsening their crises risk. You prevent infections, specifically strep, with penicillin. They're also going to have home oxygen monitoring. Okay. Home oxygen was needed to prevent hypoxia. His pain has been managed with Tylenol and Tylenol with codeine. He has received periodic transfusions of red blood cell exchanges as an outpatient. He's required several blood transfusions in the last 8 months, with the most recent one being yesterday. He is now here because he has a vaso-occlusive episode. Okay. So what are the characteristics of vaso-occlusive crises?
High fever.
What was that? I'm sorry.
High fever.
Yep. He's got a fever. Yep.
Respiratory distress.
Yep. Joint pain, right? So that
Yeah.
could mean that his occlusion could be in, his vessels around his knee joint, potentially. Yep.
Pain. Joint pain. Yeah, right. Pain.
Yep, joint pain in this one. Yep. Shortness of breath and fatigue, right? So those are all potential signs for this kiddo that, he's probably in a vaso-occlusive crisis. Okay, what do you think his triggers are with reading this? Potentially.
Disease, pneumonia.
Well,
No, it's 5
he had
years. Yeah, I'm sorry.
Nope, that's okay. He had pneumonia before. But what about his home oxygen? He was starting to need home oxygen. So what is that telling you? He's becoming hypoxic, right?
Mm-hmm.
Yeah. So stress from that plus his pain, right? Those are kind of some triggers. So how did they manage him right now? How are they managing him? Like at home.
Fluids, blood transfusions,
And Tylenol.
and pain management.
Yep. Oxygen, right? At home too, they're giving him oxygen. And then also the penicillin prophylaxis. Okay. So he comes to us on the floor and he's still having a lot of pain. What do you think kind of the next escalation if the Tylenol and the Tylenol with codeine orally aren't cutting it? That this kiddo is probably going to need.
Opiates?
Yeah. Well, the Tylenol and codeine is an opiate,
Well,
right?
like a stronger, like
Yes,
maybe
like
morphine?
IV
IV.
pain meds. Yep. So whether it's
Pump.
fentanyl or morphine, yep, on a PCA pump potentially. He's 16, so he should be able to, be responsible with a PCA pump. Littler kids, you kind of get worried about them not being able to push their button appropriately and parents maybe pushing the button for them. Okay. What else would be another thing that he would need in the hospital?
Emotional support.
Yeah. Yep.
Like his schoolmates.
Yep. That's good for development, right? But what about his actual care? So pain management, and remember the other thing I said that these kids when they're in crisis need?
A consistent caregiver?
Fluids. IV hydration. Okay. Because the idea is if you almost not overhydrate them, but appropriately hydrate them, okay, then you can kind of break up that occlusion. Okay. Okay. Thalassemia.
Question: do they usually give normal saline on that or hydrochloride?
Usually it's normal saline, but it depends on if their potassium or something like that is off as well. Like if their electrolytes are off a little bit, they may use like half normal saline with some potassium or normal saline with potassium. But usually if you're bolusing, you're going to be using either normal saline or lactated ringers. Those are your two that you bolus with. Most commonly normal saline.
Thank you.
Good question. Yep, good question. Okay, so thalassemia. So this is a group of hereditary blood disorders. Okay, still falling under the anemia category, okay? So this is looking at the adult hemoglobin. So thalassemia, there's abnormal size blood cells that then are being destroyed because they're abnormally sized. And then these kids continue to have a chronic anemia. Okay. the body tries to then compensate by producing larger amounts of fetal hemoglobin. Okay. There's two forms. There is thalassemia major, which is Cooley's anemia. This is probably the most common, like when you read about thalassemia, usually Cooley's anemia is the one that pops up the most. But there's also thalassemia minor. So thalassemia major or Cooley's anemia is a progressive severe anemia that prevents within the second 6 months of life. So after 6 months of age, because remember, until we're 6 months of age, most babies still have their parents or their mom's blood, circulating, and iron circulating. Okay. So we typically don't start to see the anemias come about until after 6 months of age. Okay. Thalassemia, do you guys remember which ethnicity is most common for thalassemia to occur?
Mediterranean,
Yes.
like Italy, Spain, all this stuff.
Yep. Greek. Yep. All of that area, the Mediterranean area. Yep. So that's the most common ethnic population that has thalassemia. So kids with thalassemia major or Cooley's anemia, they're also at risk for hemosiderosis, which is iron deposits in the tissue. Okay, so buildup of iron within the tissue. Eventually, these kids will have cardiac failure if their anemia is not addressed. So all of these people who have anemia, if their anemia isn't corrected, eventually your heart muscle gets too weak and it can't continue to function and we get to cardiac failure. Okay. Not that it can't always be corrected or reversed, but sometimes you're kind of past the point of correction. Okay. Kids with thalassemia major specifically will also have large abdomens. Okay, so they're going to have abdominal distension because of their organs becoming larger to try and kind of accommodate that change. Okay. They're going to be pale. They're going to be hypoxic. They're going to have poor appetite because of the breakdown of all the toxins. A lot of times they're also jaundice. Okay. So they're going to have kind of that yellowing of the skin as well. They're going to have an enlarged liver and an enlarged spleen, and that's because of those that breakdown of those red blood cells and that pooling that occurs, similar to with sickle cell. Okay. The bone marrow space also has to enlarge to compensate for the increased large blood cell production, which then that kind of leads to these facial abnormalities that you see in this little girl, like more of a flat nasal bridge, more prominent kind of forehead. Okay. Thalassemia minor is more of a mild anemia, and a lot of times it gets confused with iron deficiency anemia. So if you don't do iron studies with your CBC and that kiddo's anemic, then it's possible that that kiddo maybe has a thalassemia minor. Okay. With thalassemia, the shape of the red blood cells, they're almost kind of more like rectangular versus circular. Okay. And it occurs from spontaneous mutations. So this isn't something that you have to have, parents may have this, they may not have it, and that kiddo just has a spontaneous mutation that led to them having thalassemia. Okay. It's not like sickle cell where you have to get it from both parents, that trait, to be then affected. Okay. All right. So hemophilia is the next type of anemia we're going to talk about. It's one of the oldest hereditary blood diseases, causes the blood to not clot normally. Okay. It's most common in males, but it can be passed along by females who don't have any symptoms. Okay. Most common type is hemophilia B, Christmas disease, or factor IX deficiency. Okay. And hemophilia A, which is a deficiency in factor VIII. Okay. So in looking for hemophilia, you need to look at the blood clotting, how long it takes for the blood to clot. So that you're having to look at a PTT, which is a partial thromblastin time. You'll see PTINR like with elderly people when they have to be on anticoagulants, okay? You would be checking that as well in these kids. But the key in detection for hemophilia, either A or B, is that PTT, okay? Hemophilia A is almost the most common cause. It's like 85% of hemophilia is hemophilia A. Okay. It's caused by a deficiency in factor VIII. Okay. Depending on the amount of the factor VIII that's deficient is going to lead to these kids being more at risk for bleeding. Okay. So kids who have hemophilia A, if they run into something, scratch themselves, the tiniest little scratch, they're internally going to have an accumulation of blood in that area. Okay. Or they may bleed and bleed and bleed forever from that tiny little scratch, and it's very hard to get that to stop. Okay. The aim of therapy with either factor IX deficiency, Christmas disease, hemophilia B, or hemophilia A, factor VIII deficiency, is obviously to increase that factor. So that way you make sure that they're clotting appropriately. Okay. And a deficiency in any of the clotting factors can obviously interfere with normal blood clotting. So it's not just specifically those two, but those are the most common. Okay. Diagnosed at birth, usually hemophilia A specifically, because factor VIII is not something that crosses the placenta and transfers to the fetus. Okay. So usually you don't notice it super early on. Usually what you start to notice is abnormal bleeding from the umbilical cord or after circumcision. They're just bleeding and bleeding and bleeding. You can't get it to stop. That would be a sign potentially that this kiddo may have hemophilia. Okay. Normal blood clots typically in 3 to 6 minutes, and severe hemophilia can take up to an hour or longer. So these kids are going to bleed and bleed and bleed. And even holding pressure, that might help a little bit, right? But they're still going to continue to, every time you check, they're still going to be bleeding. They're going to have anemia. They're going to have leukocytosis, which is low white blood cells, okay? They're going to have an increase in platelets because their platelets are trying to account for that clotting. That's not happening, okay? You may see blood in the urine, okay? It's not uncommon to see blood in the urine. And then, of course, if we're excessively bleeding and that bleeding's occurring, in the area of the brain or the neck, then it can result eventually in death. Severe headache, vomiting, disorientation, that may all be suggestive of, there's potential bleeding in the brain. Okay. You also can see, like infants, they have to have their blood work done for their newborn metabolic panel and all of that shortly after birth. So those heel sticks those vaccines that they get, they're going to be oozing blood from those areas for longer periods of time. So if you would notice that as a nurse, it'd be really important to let that provider know right away. Okay. Obviously, people who have hemophilia should not be on anticoags, right? Or things that can interfere with our platelets. So no aspirin use and no NSAID use, okay? Ideally, also, these kids are not in contact sports because they may just get bumped into by another kiddo, and then they can start internally bleeding, okay? So critical thinking question. Parents of a 9-year-old boy are confused about their son's diagnosis and treatment for hemophilia A. They don't want to excessively limit their child's activities, but they're concerned about how to prevent bleeding, how to treat it if it occurs. So what information or counseling should the nurse provide? So what's the treatment? Giving them factor VIII, right? Because they're deficient in that.
Teaches them not to participate in like competitive sports and high impact like box, contact sports, yeah.
Yep. Or maybe they can participate in another sport that's not so, there's not so much risk for contact, right?
Teaches a kid if he has like any injury, he has to tell somebody about
Yes.
not to
Yes.
hide.
Yes, not to worry about. Yep, good. What else? Anyone else have any thoughts? So like I said, they'll be given factor VIII. It used to be pulled out when people donate blood and then given, and then the scare kind of with HIV and with hepatitis risk, then they developed a synthetic form of the anti-hemophobic factor, which can be administered at home. So if these kiddos do wind up with a cut or something like that, then the parents are told to give that then at home, or they may have to come into the hospital to have that transfusion. But essentially it's a synthetic form of factor VIII. Okay. Okay, so platelet disorders. So idiopathic or immunologic thrombocytopenic purpura, that's kind of a mouthful. ITP is another term for it. So it's one of the most common platelet disorders, specifically in toddlerhood, early, like preschool age kids. So from 2 to 4 years of age. Now, with that being said, it can happen in older kids, but most commonly in that toddler kind of age group. It's unknown cause. Essentially, the platelets become flagged by your immune system, saying that they're an invader when they are not, and then your antiplatelet antibodies then start destroying those platelets, thinking that they're an infection or something like that that's going to attack the body. Okay. And interestingly enough, you guys can all say someone who had this, because I had this when I was a kid. And this was very early on, when they didn't really understand the mechanism of it all. They treated it similar to leukemia and things, minus doing chemotherapy, but they gave you a bunch of platelet transfusions. Well, if they're giving you more platelet transfusions and your body's recognizing those platelets as foreign, what's going to continue to happen? More destruction, right? Yeah. So instead of doing that now, they figured out that they give you IVIG or immune globulins to kind of help re-regulate your immune system from flagging those platelets as abnormal, okay? So these kids will get steroids and they'll get IVIG. It's identified or diagnosed similarly to how we look at diagnosing cancers. So, right, we're aspirating that bone marrow out from the iliac crest or at the top of the hip, which you can see that right there on that picture. Okay. Easy bruising, petechiae and purpura, which are those really bright red, teeny tiny little bruisings that when you put your finger over them, they do not blanch. Okay. A lot of times it can be after respiratory infections, such as influenza or rubella or rubeola are another couple viral things, which we don't see rubella and rubeola that often because we have the MMR vaccine, but it's still something that can happen. Usually something has happened a couple weeks prior to IP or ITP starting in the form of a viral illness. Platelets, their platelets are going to be less than 20,000, which is very, very low. Normal is 150 to 450,000. Okay. Like I said, diagnosed with bone marrow aspiration. So like I said, IVIG, anti-D antibody, if there's further clotting, and then IV corticosteroids or which is prednisone steroid, okay, or oral. Okay. These kids need frequent monitoring of their neurologic status because obviously if their platelets aren't functioning appropriately, they're at risk for bleeds in the brain. Okay. So you're going to be wanting to make sure that these kids are alert, they're oriented, they have their cranial nerves are intact, they have good reflexes, their speech is normal, they're not having any abnormalities in their neurological assessments. If they start to have some abnormalities, then get the provider right away. Okay.
So this is a lifelong disease, or
Nope.
they can...
Nope. Usually it's just one episode and then you don't continue to have them. There is a form of chronic ITP, so that, you know, they may, if they get an infection, they may have another kind of flare up of the ITP, but most commonly they kind of get it once and then they get the steroids and the IVIG, and then it resolves. Now, you don't want these kids to get aspirin. You don't want them to have a lot of caffeine or fetal bunzone or phenicin. You don't want to do any of those because those all increase the breakdown of platelets.
I'm sorry, what is the phenacetin?
It's a oops, sorry. It is a it's an NSAID. So like aspirin.
Okay.
It's one that's really not used. I mean, I haven't seen it used in.
That's what I was asking. I've never seen it before. It looked kind of like the phenytoin, so I was wondering if it was related to that, but yeah.
Nope, it's a form of an NSAID or like a fever reducer. But like I said, I don't even know that it's utilized in the US any longer. But essentially anything that can affect the platelets development, you want to stay away from. And caffeine can actually have an effect on your platelets. So when kids are in the acute stage of ITP, they should obviously do things that avoid getting a lot of more bruising or having more risk of bleeding. Okay. And then, like I said, they used to give platelets and then they realized that that makes everything worse. So they're not typically giving platelets. They typically do the IVIG and the steroids and kind of keep kids in the hospital, make sure that their platelets start recovering, and then they send them home. Okay, complications, like I said, in intracranial hemorrhage, obviously GI bleeds, bleeding into the joints, that's hemoarthritis, or arthrosis is bleeding into those joint spaces. Immunizations, making sure that these kids get their immunizations so that way they're not getting those viral diseases that increase their risk. So like I said, the MMR vaccine, because rubella and rubeola are common causes of ITP. Okay. Okay, now we're going to start talking about white blood cell disorders. So obviously the most common cause of childhood cancer is leukemia, which is a malignant disease of the bone marrow and the lymphatic system. So leukemia causes an uncontrolled growth of immature white blood cells. So it's just cranking out because it sees that your body is being affected and it needs more white blood cells to try and fight those infections off. So they're just cranking, your body's just cranking it out as fast and fast and fast as it can and not letting them mature, those white blood cells mature so they can actually fight off the infection. It just kind of sets this overproduction of the white blood cells, immature white blood cells in the bone marrow, okay? It also kind of takes over because it shifts to cranking out those white blood cells. It's not making as many red blood cells in the bone marrow. So you're going to also see anemias. These kids are also going to have more weakened bones. Okay. Leukemias are classified based on the cytochemical markers and chromosome studies and immunologic workups. So the most common causes are ALL, so acute lymphoid lymphoma, or AML, or AMLL. So AML and AMLL are the same thing. So it's acute non-lymphoid or myelogenic leukemia. So like I said, when you're concerned about a kid having leukemia, they have that bone marrow aspiration, and then they look at all of those cytochemicals and the chromosome studies and the immunologic markers, and that's how they classify the type of leukemia. And we're talking about acute types because these are the two most common in kids. Now in adults, there's chronic type leukemia. Okay. Okay, I have a couple little chats here, so hang on one second. I'm going to look at those. Yes, do whatever you guys need to do. If you're not feeling well, then you can hop off. That's okay. Just know that, you won't be receiving the attendance, but that's totally fine. I understand. Okay, so your most common symptoms of leukemia initially are going to be low-grade intermittent fever. So they're going to kind of have just these random fevers here and there. They may not have a lot of other like sickness type symptoms. So they may not have cough, congestion, that a reason for the fever. They're a lot of times going to be more pale. They might have more of a bruising tendency, and they might have leg or joint pain. That's probably one of the most common signs. So if you have a parent bringing their kiddo in and they've had like low-grade fever and not really any symptoms and joint pain and belly pain and maybe a couple lymph nodes, places enlarged, then you really want to have leukemia in the back of your mind as a potential thing that's going on with them. Okay. Also with leukemia, like I said, because of that breakdown and that overproduction of the immature white blood cells, they're going to be anemic because they're not cranking out as many red blood cells. So you'll see these kids, you'll give them some blood maybe because they were anemic, and then they're in, a couple weeks later and they're anemic again. So that's kind of another sign too. or they don't bump up. You know, if you get a unit of blood, you know, you should bump up at least 1 to 2 mils, your hemoglobin should. When you do your hemoglobin level, it should bump up 1 to 2 levels after you get a unit. And in kids with leukemia or people with leukemia, you won't see it increase very much. Okay. The liver and the spleen become enlarged because, like I said, that destruction is going on. The skin may have kind of a lemon yellow color to it. So a little jaundice, right? Because of the liver enlargement that's going on. And petechiae and purpura. So we also saw petechiae and purpura with ITP. Okay. So that's why we have to kind of investigate both of those avenues potentially. Okay. A lot of times unexplained weight loss is another sign of leukemia. They can be really quick onset. They can be really gradual onset. It just kind of depends on the severity and the category of leukemia. So diagnosis, like I said, a lot of blood tests. They're going to have x-rays done of their long bones to see if there's been any change. So like femurs and humerus to see if there's been any changes over the time period, or if there's any tumors or lymph node involvement in those areas. They're also going to get a spinal tap to see if there is any involvement in the CNS system. They're also going to get that bone marrow aspiration. Okay. So they're going to have a huge workup. Okay. So your blood tests, like I said, you'll see leukemic blast cells in the blood and bone marrow or the tissues. Which blast cells, those just mean essentially immature white blood cells. Kidney and liver function is also looked at. That's mostly because the treatment obviously is chemotherapy. And if we already have poor kidney and liver function, we want to try to correct that as best as possible prior to starting the chemotherapy. Treatment can be radiation and chemotherapy, typically chemotherapy first. The induction period is a period of time, kind of the first step of chemotherapy right after diagnosis. It's very intense. It's usually about a month long, depending on the protocol, but it's very intense. These kids a lot of times are hospitalized for the whole induction period. They also do treatment of the CNS, so like an intrathecal is what it's called. So that's actually within the spinal canal in the CNS system. They'll do a spinal tap and they'll actually put chemotherapy within that area to try to prevent the CNS from becoming involved in those high-risk kids with leukemia. Maintenance therapy then is kind of a routine, like they come every month for their therapy. And then eventually, hopefully they get to remission, which then they're not getting any therapies. If they relapse, so if the cancer comes back, then they start over with reinduction, okay? And then they may also wind up getting extramedullary disease therapy. So if there's other involvement or metastasis or something, then those will be added as well. Steroids. This is also something that's given sometimes with chemotherapy, are steroids to kind of help the potential of infections and kind of boost that immune system. Obviously, steroids have a lot of side effects. So they might start to have that moon-shaped face. They might have fluid retention, personality changes. So they might get that roid rage that we've all heard about going on. But typically, steroids are a part of the induction phase for leukemia treatments. Chemotherapy, obviously, hair loss, nausea, diarrhea, rashes, bone marrow depression. That's the point of it, right? Is to depress that bone marrow, that production of those immature white blood cells. And chemotherapy obviously kills off the bad cells, right? The cancer cells, but also the good cells. So you have to kind of balance that. Kids who get chemotherapy may also have decreased sensation. So they'll have peripheral neuropathies. And they may also have severe constipation because of that decreased nerve sensation. Eventually, bone marrow transplant may be needed if the chemotherapy and radiation treatments are not helpful to these kiddos. So caring for a child with leukemia or any cancer, you are going to obviously need to have a lot of emotional support for these kids and also these families. So allow them to verbalize their feelings, allow them to know that it's okay to verbalize how they're feeling and talk with you. But one of the biggest things you're going to be watching for in these kids who are in treatment are signs of infection. So that could be something like a teeny tiny little cut on their lip because, you know, they didn't drink very well with their water. Now they have a little cut, and then, you know, all of a sudden their, you know, their immune system isn't functioning normally. So they can't make the immune response to that little cut to fight off any little teeny tiny bacteria. And, you know, they get a significant infection. So watching for fevers, for any signs of infection, changes in vital signs, skin breakdown. That's going to be all really important stuff that you will do as a nurse with kids who have leukemia. The other thing is really meticulous mouth and skin care. Like I said, watching for ulcers. A lot of times you'll give these kids kind of like a preventative kind of mouthwash, so that way they're not getting infections within their mouth. Hodgkin lymphoma. So Hodgkin's disease. This is a malignancy of the lymph node system, or the lymph system, specifically within the lymph nodes. Okay, so it starts within the lymph nodes. So usually you notice, parents will notice a painful enlarged lymph node, or painless, excuse me, enlarged lymph node. No pain in these lymph nodes, okay? Eventually, as that continues to progress, they may have the low-grade fevers. They may have unexplained weight loss, night sweats, just generalized kind of fatigue, rash. Eventually, if it's not recognized as Hodgkin's disease, this can metastasize to the liver, bone marrow, lungs, spleen, essentially anywhere, because it starts within the lymphatic system, which our lymphatic system, you saw all the passages of the lymphatic system in the first slide. So it can go anywhere within the body. So Reed-Sternberg cells are used to diagnose this disease. Okay, so they look at the blood and they find those Reed-Sternberg cells. Almost never seen before age 5, most commonly during adolescence and early adulthood. Twice as likely to happen in boys than in girls. Okay. These kids are going to have radiation and chemotherapy almost always. And the cure is primarily related to the stage of diagnosis. So if they have a lot of metastasis places, it's going to be a lot harder to find a cure for them. Okay. But with Hodgkin lymphoma and leukemia, both the long-term prognosis is very good. Like cure rate is very, very high. It's like almost 95% cure rate for both of those. Now, of course, like I said, if there's a lot of metastasis and things like that, then you get concerned about it not being as curable. But if it's caught fairly early, pretty good long-term prognosis. Okay, so when caring for the parents of a child with Hodgkin's lymphoma, what are you as a nurse going to be looking at doing?
Making sure that you're checking their skin for any breakdowns so they don't get in any infections. Roll them often.
Yep. Yep. What about they're getting, oh, go ahead, Melissa.
Sorry, I was just going to talk about the precautions. Like, I don't know if they do neutropenic precautions after.
After chemotherapy. Yep. Yep. And they would also do neutropenic precautions. Same thing with leukemia patients. Yep.
Treating nausea.
Yep. Treating their side effects. So yeah, nausea, anorexia. They might need an appetite.
Yeah, good nutrition.
Yep. A stimulant for their appetite. You may also need to educate. So when kids get radiation and chemotherapy, you know, with this age group specifically, Hodgkin lymphoma kiddos, they're in the puberty age, right? So they may have just gained their potential for fertility. But unfortunately, when radiation and chemo have to happen, sterility, so these kids becoming sterile, can happen. So having that conversation with parents and the child also about, like, you know, if you feel that someday in your life, you know, you want to try to have kiddos of your own, you know, maybe we need to collect some eggs before we start chemotherapy or we start radiation therapy, or we need to collect you know, some sperm or something like that. So you need to have those conversations with these kids. It kind of seems crazy to have those conversations with kids, but that is something that's important, because I think a lot of times that's something that's forgotten. And then, you know, they go through all the treatment, they get cured, and then they go on to have their own family, and they have a very hard time doing that. So kids who are chronically ill and hospitalized, they're going to most likely have more struggles with behaviors, right? Because they don't necessarily know the best way to work through their feelings. And they may not be able to verbalize all of their concerns about their chronic illness. So they may feel rejected by their peers. You know, they're hospitalized, they're in the hospital a lot. You know, they may have lost their hair. So that can be a part of a struggle. Think about adolescent age kids that care about their appearance. So think about where they're at. They may have scarring or you know, more redness in the area of where their radiation therapy was done. So it's important to think about those things developmentally with these kids, and trying to meet their needs, you know, while they are chronically hospitalized or dealing with chronic illness. So developmental disabilities. So kids with developmental disabilities are often overprotected, or they're unable to break away from supervision, or, you know, they're deprived of those peer relationships. Okay. So what are some things that you can assist parents with in kind of dealing with these potential disabilities? So could you
Maybe educate them on, you know, special places that take in adolescents or kids with developmental disabilities, so they go out and do fun, you know, like I know that there's places they can go for like day treatment or you know.
like a day camp kind of.
Yes, exactly.
Yep, where they get that peer interaction and that peer
Right.
relationships. Yep. So that's a huge thing. And then also working with parents on trying to kind of be aware of some of the things that they may encounter in kids with disabilities and with chronic illness as well, and kind of how they can try to navigate that and combat that. So chronically ill kiddos, obviously focusing on what the child can do and having them be successful in doing that is more productive than focusing on that disability, right? So, or all the things that they can't do. So trying to encourage them to do things that they can do, and that, eventually when we're no longer ill or things, hopefully we can go back to being able to do all of the things that we want to do. Okay. Having that child have normal family interaction is probably one of the biggest struggles, I think, with kids who have been diagnosed with cancers or chronic illnesses. The kids and their families struggle with, just because, especially if they have other siblings, because those other siblings will see that kiddo maybe gets more attention because they're chronically ill, or they get special rules, or etc. And then that can cause kind of a lot of tension within the family. So trying to have everyone in the family aware and involved in that interaction, and trying to keep things as normal as possible through the diagnostic process and the treatment process of the kiddos who are chronically ill. Okay. The wellness of the child rather than the disability should be the center of the child's life. Okay. So getting them well versus the cancer or the thing that they're managing. And think about developmentally how each age group, you may have to change your care of each child a little bit based on their developmental age. Okay. So there's a table, I think it's page 651 in the textbooks, that talks about some things that you can do, or things to be aware of based on their age with chronically ill children. Okay, so obviously in talking about lymphoma and leukemia and these cancers and lymphatic issues, obviously a concern is the child ending up dying, okay? So you as a nurse will have to understand the grieving process. This is across the board for adults and kids, okay? You have to understand the process, and that everyone processes grief differently. So there's going to be a wide range of emotions. No single way is okay. Obviously you should feel safe with someone who's in the grieving process. And if you don't, then that's a little bit of a different scenario. But there can be feelings of rage. There can be bargaining, like attempting to negotiate or delay that child's death, whether that be with providers or with God, God, or whatever kind of theologic thing that they follow. Denial, so like thinking that there's not going to be a potential death. So there's different steps. Depression, so obviously overwhelming sadness, regret, sense of loss, and then eventually acceptance. Okay. These parents in these families do not have to go through them in a step-based process. So they may not go from bargaining to depression to acceptance. They may go from denial to bargaining to acceptance. They may skip depression. Okay, it's just different for each family. Okay, or they may go back and revisit certain stages multiple times through the grieving process. It's very personal. You guys will need to be kind of this family's rock through this. You very much as nurses are the empathetic care providers. So, you need to allow these parents to have these feelings and know that it's okay for them to have these feelings. Okay. the response to a child's death can be influenced, if it was very sudden and unexpected, those parents are going to act much differently, usually with their grieving process, than if they've had a long time where death is kind of, almost certain. It just is kind of when it's going to happen. Is kind of the two different avenues potentially of the grieving process. But that doesn't mean that kids or that parents or families who have known that their child was going to eventually die, they have a terminal illness, that doesn't mean that they may progress through the grieving process easier. So essentially be a listening ear for these people, respect their cultural beliefs. Okay. So, we kind of already talked about all this. So allow them to cope, adapt, grieve. Know that hostility can be a normal response. Okay. And it's okay for them to be a little bit hostile, but obviously you have to protect yourself as a nurse as well. Okay. So the child's reaction to death. So you need to look at that child's cognitive developmental stage versus their chronological age, because, they may be a teenager, but they may function like a 5-year-old. So think about where that child's at cognitively. Okay. Kids younger than 5 are usually concerned with abandoning their parents, when they're facing death themselves. Preschool kids a lot of times have questions about death, and they kind of make those answers up based on kind of a fantasy land. You can think about developmentally where those preschool age kids are. Children do not necessarily have a realistic concept of the finality and the permanence of death until 9 to 10 years of age. Okay. Physical changes of impending death. So on your, assessments, you're going to start to notice these things changing. They're going to start having loss of consciousness. Their hearing may still be intact, but they're not maybe as responsive to you. They're going to start having more wet lung sounds. So they're going to start having more gunky rails in their lung sounds. And that's because of that pooling of the secretions in the lungs. They're not able to, pump it out and get it circulated and get it out like they once were. Cool, mottled, cyanotic skin. Do you know what I mean by mottled? So really splotchy looking skin. And their neurological signs, so their neurological function and their movements start to decrease. Okay, so you'll see changes in their breathing pattern, all of that. Changes in their cardiac function. Okay, any questions about lymphatic and hemolytic stuff? No? Okay, we'll move on to GI. Those are your objectives. Once again, I'm not going to read them to you. So overview of the GI system. So obviously the purpose of the GI system is to transport and metabolize nutrients for the life of the cell. It extends from the mouth all the way through the GI tract to the anus. Nutrients are broken down and then absorbed by various enzymes and various digestive organisms or organs. Okay. So labs that may have significance in kids with GI dysfunction, you want to look at CBCs to see if it's anemia or an infection or a chronic illness. The erythrosedimentation rate or ESR, so that's indicative of an inflammatory process going on. So if they have like an inflammatory bowel disorder or Crohn's or something like that, that would be elevated likely. a CBC, which is a comprehensive chemistry panel. So that would check for like electrolyte imbalances. Okay. Liver function tests. If you did a CMP, you would see some liver function tests. So those might be off if the liver is involved in the GI dysfunction. Looking at stool cultures, X-rays, so a barium enema or a swallow study that looks at the function of the GI tract. An endoscopy, so a scope, either upper, so they go through the esophagus to the stomach, looking at the small intestine, the bile ducts, the pancreatic ducts, or a lower, which, you know, then is looking at the colon, the sigmoid portion, the lower colon, or the entire colon, colonoscopy. So sigmoidoscopy is the lower colon only, and the entire colon is a colonoscopy. So some common signs of GI dysfunction: failure to thrive. So they're not getting enough nutrients absorbed to grow appropriately. So that would be a sign potentially of GI dysfunction. Itching actually is a very common cause or sign of liver dysfunction. So if you have a kiddo that's like itching all the time, and you send them to the allergist because, you know, they're itching, so you want to make sure that if they're allergic to something, you have them not be around that. But you send them to the allergist and they have no allergies, you might be concerned about then liver dysfunction at that time. Local signs of GI tract dysfunction: pain, vomiting, diarrhea, constipation, hematemesis, so throwing up blood, rectal bleeding. Those are all concerning signs for a GI dysfunction. Congenital disorders, so EA, so esophageal atresia or tracheoesophageal fistula, same thing, okay? It's just where the esophagus, or which parts of the esophagus are involved, okay? So this is a failure of the tissue of the GI tract to properly form in prenatal life, okay? So there's 4 types: the upper and the lower esophagus from the stomach, then connects into the trachea. So that's type A. The other option is the upper esophagus ends in a blind pouch. So you can see right here, B, here's their esophagus. Okay, it just doesn't connect. Okay, doesn't connect. So the upper esophagus ends in a blind pouch, and then it connects, the lower esophagus connects then to the trachea. These kids, you're going to notice they're going to seem like they're drowning when they're trying to eat. They're going to become, they're going to start choking. They're going to start coughing when they're feeding, because that food, that liquid, is going straight into their trachea instead of going to the stomach like it should. Okay. They're going to be cyanotic. They're going to have apnea episodes, especially when they're eating. If the lower end of the esophagus enters the trachea, the air will also enter the stomach every time that kiddo takes a breath. So they're going to have significant abdominal distension. Okay. Nursing care wise, obviously you are concerned this kiddo is inhaling food into their lungs every time they're eating, potentially. So what can you get if you're, or what would be the risk, potentially the biggest risk in this kiddo for infection?
Aspiration pneumonia.
Exactly. So aspiration pneumonia is probably one of the most common issues you see in these kids, but also they're not getting those nutrients like they should, right? So they're not going to grow appropriately. This is going to be something that is surgically repaired very, very early on at a very young age, because it's essential for survival. Okay. When it is repaired and they're starting to kind of start to refeed again, They're going to usually start with water or colostrum because that minimizes the significance of potential aspiration risks. And they will do a little bit of water or colostrum until they're able to do surgery on these babies. But surgery is almost always done within a couple days of life. Okay, in perforate anus. So this is when the lower GI tract and the anus, they're made from two different types of tissues. And when the two tissues meet, there's a perforation, so an opening or a passageway. Okay. And if that does not take place, then there's that blind pouch. So they don't have the external opening. Okay. There's 4 different types depending on the severity. Okay. You're going to see these babies. They are not going to have a meconium stool in the first 24 hours. Okay. So if you are taking care of babies right after birth and they're not having a meconium stool within the first 24 hours, you should be really concerned about imperforate anus. Okay. Infants should not go home until they've had at least 1 meconium stool pass. Okay. Once they realize that this kiddo has imperforate anus, then they need that infant to be NPO and they'll start preparing for surgery. The initial step of the procedure is a colostomy, okay? And then subsequent surgeries will then reestablish the opening of that anal canal and then reverse their colostomy, okay? So what's the purpose of starting with a colostomy on these kiddos? Like, why wouldn't they just go in and reconnect everything and create an opening all in once?
Because those babies, they when they're first born, they don't have a clotting factor. So that's why they wouldn't have like surgery right then. And then they will have the colostomy bag so that they can eat.
Yeah,
No,
so they
it's
can
gonna get it out.
eliminate waste. Yep. Yep. Yep.
It's gonna get it out. And then I guess when the child gets a little older, then they'll go through anal surgery.
Yep. Yep. So essentially, anesthesia risks and all of that, kids being under for longer periods of time, like the length of time that it would take to, connect everything together, like how it should be and create an external opening would be pretty lengthy for a newborn essentially to be under anesthesia. So that's why they revert to the colostomy first. And then they wait usually until they're a few months old and then create the external opening when they can tolerate being under anesthesia for a longer period of time. Okay. Okay, pyloric stenosis. So this is an obstruction at, which you can see this here. Here's this thickened pyloric muscle. So it's an obstruction at the pyloric sphincter of the stomach. So the lower end of the stomach, right before it goes into the small bowel, the duodenum, okay? So it gets really thick and it causes a narrowing, so sphincter, right? And a narrowing. And then, stenosis, so narrowing. You can feel this most commonly in that upper abdomen. You will feel like an olive-shaped mass. The parents will also tell you, like, my kid has been projectile vomiting starting usually about 2 to 3 weeks of age. So every time they eat, they're projectile vomiting, okay? And parents will say projectile vomiting to you a lot. But this is literally like you have the infant on your chest and they're hitting the wall across the room with their vomit. That's how forceful it is. So it's very much projectile vomiting. And like I said, you also feel that olive-shaped mass. A lot of times these kids will be dehydrated because they're vomiting their nutrients. Okay. More common in boys than girls. Okay. They're going to go in and they're going to open up that opening. with surgery, okay? One of the most common reasons babies need surgery, okay? So let's think about this one. So Mario was nursing well for the first week after delivery. Last week he started vomiting with each of his feedings. Didn't think too much about it as her first son had reflux. This week he's been throwing up more frequently. He vomits after every feeding now. The vomit flew across the room. There's a little blood in it. So that's why she called for the appointment. He's usually calm after eating. Now he's very cranky. He's losing weight. What do you think's going on? So obviously it's pyloric stenosis, right? But what are the signs that mom's telling you that would lead you to believe that it's pyloric stenosis?
Yeah, it didn't develop right after birth. It like took a while.
Took a little bit, yeah.
He vomits every feeding.
And it's projectile, right? Across the room. Has a little bit of blood, so you can tell his stomach is irritated.
He tires when feeding.
Yeah,
Is
he's
that-
more
yeah.
he's more cranky, right? Irritable.
Cranky, yeah.
So these babies won't necessarily tire with feeding. They'll be super angry while they're trying to eat because they're not getting and keeping down the nutrients that they need. So they'll be really like, they won't latch. They'll start eating. They get kind of irritated because they can't get it down and absorb it enough. And then obviously losing weight, right? He's losing weight now. So that's another concerning factor. Okay, so what do you expect to find when you're examining this kiddo? What are you going to feel?
An olive-shaped mass.
Yes. Good. Yes. Okay, celiac disease. So this is a gluten enteropathy, okay? So this is repeated exposure to gluten that damage the villi of the intestines, which then result in malabsorption. So the rule of the villi in the intestines, they're tiny little finger-like projections in the intestines, in the small intestine specifically, that absorbs the nutrients from the food that we eat. And then they kind of shuttle it down to the bloodstream so it can go where it needs to go. So with the damage of the villi, then that process isn't completed. So they're not able to result or to absorb those nutrients like they should. So they have malabsorption. Okay. You'll see abdominal distension. The other interesting thing or kind of weird thing that you'll see is atrophy of the buttocks muscle. Okay. Usually these kids don't have any symptoms until 6 months to 2 years of age. That's because they're not eating gluten typically before that, right? So they're not having wheat, they're not having oats, rye, barley, things that contain gluten before 6 months of age. The classic, like I said, the villi atrophy in the small intestines, and then that leads to malabsorption and diarrhea and abdominal pain. Atypical, so that's when the duodenum is also involved. They may have mild kind of GI symptoms. It may be anemic, maybe a little fatigued, constipation. Silent form is they have intestinal atrophy that's maybe found on endoscopy or biopsy, or they have a positive blood result. So they aren't having like a lot of signs of celiac disease, but you know, you do a blood test and you find that they have tissue transglutaminase, IgA, so their immune globulin is positive. So then that leads then to them having a whole workup where they have a scope done and they find that villi damage. Okay. A latent form of celiac disease means that they may not have like the atrophy of the villi, but when they eat wheat containing foods, they get a recurring rash. So you'll see some kids have like almost like vitiligo. You know what I mean with vitiligo? So a more hypopigmented spot on their face. So you'll see kids with latent celiac disease. Sometimes they'll get hypopigmented spots on their face, or geographic tongue, which is like patchy kind of looking spots on their tongue. Okay. Obviously, to combat celiac disease, we manage that by diet. So these kids are no longer able to eat gluten-containing foods. Okay. Involving nutritionists and dietitians can really help parents. These kids are also going to have really large, bulky, frothy kind of stools. Okay. In infancy, they're going to have failure to thrive. Same with if they're older kiddos, diagnosing that. Okay, Hirschsprung's disease or aganglionic megacolon. So this is essentially the absence of ganglion innervation, so ganglion nerves within the lower portion of the sigmoid colon. So this then results in a lack of peristalsis that then causes these kids to have significant constipation and ribbon-like stools. Okay. More common in boys, once again, and also more common in children who have Down syndrome. Okay, can be an acute phase thing, can also be chronic. So another sign of this will be those babies who don't pass meconium stools right away. Okay, in infancy, they can have kind of ribbon-like stools. Okay, just because that feces is trying to pass through that really narrow segment of the colon. That's why it kind of looks like ribbon. They're going to have belly distension, anorexia, failure to thrive. In older kids, if their provider hasn't figured out that they have a ganglionic megacolon or Hirschsprung's disease, these parents, a lot of times they've had to try so many different things for the constipation and nothing that they do is helpful. Okay. So like they've tried laxatives, they've tried, Senna, they've tried the chocolate X-Lax, they've tried all of that and nothing's really that helpful. Okay. So treatment, surgery is done to remove that impaired part of the colon that does not have those nerve endings to signal that they need to have a bowel movement. And then they do an anastomosis. So then they reattach that healthy colon to the other portion of the colon that then has the innervation. So that way they can have hopefully normal bowel movements after that. In early infants, you may need to do a colostomy until they're able to undergo that the more extensive repair, which is usually around 12 to 18 months. Okay. This is diagnosed by a barium enema or a rectal biopsy. Okay. Or anorectal manometry, which is they actually insert kind of a little pressure sensor into the anal sphincter, and then that measures the pressure. Okay.
I'm sorry, you said an anastomosis of that. What is that?
Anastomosis. So that's where they take out the impaired portion of the colon and then they reattach the intestine to the non-impaired portion of the colon. So that's anastomosis. So they remove that section and then reattach.
Okay.
So nursing care wise, obviously it's dependent on the age of the child, like across the board with any condition. It really looks at the age of the child as your priority first for determining your nursing care. And newborns, obviously detecting it the sooner the better. as children grow, then, you have to really pay attention to their constipation and their diarrhea history in the family history that you're getting. And then obviously if they're having signs of being undernourished or abdominal distension or poor feedings, then you're kind of getting concerned about Hirschsprung's. Okay. Okay, intussusception. So this is a slipping or a telescoping of one part of the intestines into the another part. So you can see what happens here. So the bowel essentially starts to go back into itself, kind of folding up into itself. So it's often most commonly at the ileocecal valve. This is very much an urgent need for treatment. Typically happens more commonly in boys, once again, between ages 3 months to 6 years. However, after age 3, there's a huge drop off in the risk for intussusception. They may have fevers, like significantly high fevers, like even up to 106 with intussusception. As it progresses, that child's going to show signs of shock because obviously nothing can go through that telescoped part of the colon or of the intestine. Okay, so they're going to have a weak pulse. They're going to start having shallow grunting respirations. Their belly's going to be really rigid and hard. Okay. So signs in infants, they're not going to be able to tell you what's going on, but they're going to have significant abdominal pain. They're going to be crying. They're going to be really straining to try and get, stool or something out, drawing their legs up, kicking. So if you have a really fussy infant that's doing kind of kicking and loud cries, you would want to have this on your radar as a potential cause. Kiddos will usually vomit greenish yellow, like a bilious kind of vomit. They're not going to be having bowel movements, and they're going to also be passing minimal gas. Blood and mucus with no feces are common. Okay. About 12 hours after the onset of the obstruction, then you're going to start to see current jelly stools. Okay. Because that's the only thing that can get past that tiny little telescoping. A barium enema, so an insertion of the enema and then some dye injected into that, a lot of times, or air injected into that, will cause that telescoping to reverse itself. If that doesn't happen, then they have to go in surgically and repair it. You may feel a sausage-shaped mass in the right upper abdomen. Okay. And actually the barium enema or air enema is almost 90% effective in reducing that telescoping. Okay, Meckel's diverticulum. So this is also near the ileocecal valve. So it may be connected to the umbilicus in the cord, like when they're in utero. So fistula may also form, and then the sac is subject to inflammation. So symptoms can occur at any age, but typically before age 2, they're going to get painless bleeding from the rectum. They're going to have bright red or dark red stools that are tarry, and they a lot of times have abdominal pain, but they may not have abdominal pain. So you can see kind of that little outpouching here from the intestines. That's a Meckel's diverticulum. Okay. So diagnosis-wise, they're going to do a barium enema. So they're going to inject that dye. They're going to look at how that dye progresses through the GI tract. And then that's how they find that little diverticulum. X-rays are not helpful in this. And treatment is surgery. So removing that diverticulum. And once it's removed, then they should have normal stools without that tarry kind of bright red frank blood. Once again, more common in boys. Okay. So what would be an example of a nursing intervention you should do after a kiddo had a surgical repair of Meckel's diverticulum? What would be something you would be doing? Or the most important thing to be doing?
Like assess their, not their swallow, but like their ability to tolerate feedings within the time afterwards.
Uh-huh. How could you assess that they're tolerating feedings?
By their stools.
Yes, good. Looking at their stools. Yep, good. Okay, so motility disorder. So gastroenteritis, this is an inflammation of the stomach and the intestines. Colitis is an inflammation of the colon, okay? Enterocolitis is an inflammation of the colon and the small intestines, okay? So just kind of notice the difference between those. So acute gastroenteritis is inflammation of the stomach and the intestines. So what are you going to see with kids with gastroenteritis? They're going to be vomiting. They're going to be having significant diarrhea. Okay.
Hydration.
Dehydration. Yep. Good. And it could potentially be an infectious cause, right? So it could be, you know, something like E. coli or Giardia or something like that. Or it could be something from like dairy intolerance, right? Can cause inflammation in the colon or the stomach or the intestines. Overfeeding, not properly storing or preparing formula, so like mixing formulas inappropriately, or ingesting a really high amount of sorbitol, which is a form of sugar. Okay. So obviously you get concerned about dehydration, like Jamie said, in these kids. So rehydrating is going to be one of the biggest things to do. So making sure you're hydrating these kids with maybe a Pedialyte, or if it's an infant, breast milk. But rehydrating. Contact and standard precautions until you determine a potential cause, if it's infectious or not. Okay, so you'll be in your gowns and gloves and all of that to prevent the spread of infection to others. Also, nursing wise, if you're concerned about dehydration and you're replacing electrolytes, what should you be doing?
Monitor the output and input.
Yes, strict I&O, right? So you're going to be weighing diapers, okay? That means stool diapers and wet diapers, okay? And the way you weigh a diaper is, so for each gram on a scale, a diaper weighs, it's 1 ml of either stool or urine, okay? 1 gram, it equals 1 ml, okay? And you want to make sure you put a clean diaper on, zero out your scale, and then take the clean diaper off and put the dirty diaper on, and then you can measure it accurately, okay? And like I said, 1 gram of stool or urine equals 1 ml. So that's how it's going to be charted, okay? Proper hand hygiene techniques. Teaching safe food handling, so making sure that people are washing their hands before foods and foods are cooked appropriately to those temperatures and it's all stored appropriately. And then obviously cleanliness are kind of all things that you can do to hopefully prevent gastroenteritis from occurring. Oh, sorry, my The slide looks really wonky. So vomiting. So vomiting should always be evaluated because of the potential for dehydration and electrolyte imbalance, okay? So it can potentially be signs of improper feeding techniques. So parents thinking that that baby's crying because they're starving to death and kind of continuing to feed them even though they're full, not burping that kiddo appropriately, or, you know, that kiddo is fed and then parents just kind of lay them back in their crib totally flat. So nursing care wise, you want to make sure that that infant is either propped up for a period of time. This is kind of like acid reflux kind of interventions. Propped up for a period of time after feeding. That parents are feeding and burping their infant appropriately. And then if an older child, so you're dealing with an older child who has vomiting, encourage them to lay on their side. So that way they're not laying straight on their back and then throwing up while they're asleep and then kind of aspirating that, okay? IV fluids a lot of times will be ordered in kids who have vomiting. So we're losing hydrochloric acid and sodium chloride from the stomach from the vomiting. So we're in alkalosis when we're vomiting. Now, when we have diarrhea, we're getting rid of the alkaline, right? And keeping the acidic. So we're in acidosis with diarrhea. Okay. Obviously, if kids continue to vomit, it eventually can lead to death. Gastroesophageal reflux, acid reflux, okay, very common in premature infants, but also usual infants. It can be the lower esophageal sphincter is not fully competent. So that sphincter that connects the esophagus to the stomach, that's not fully developed muscle early on until about 9 months of age. So it's very common for you lay babies down or you change their position and they spit up. Now, what you get concerned about or what is kind of more of a sign of GERD or acid reflux is they are fussy and upset when they're spitting up, okay? So common treatments. Now the American Academy of Pediatrics recommends first doing lifestyle changes just like you would with older kids and infants. So you're going to change them from a dairy formula, or if mom is consuming a lot of dairy and she's breastfeeding, then that mom needs to eliminate dairy from her diet first and try like soy formula. Or like I said, mom completely eliminate dairy. If that's not helpful and parent and kiddo's still not gaining weight, then they'll progress to a non-dairy, non-soy based formula. So like Nutramigen or Alimentum, more broken down proteins. And then if babe's still losing a lot of weight, then a lot of times that's when you see those antacids, those PPIs or HR2As started. So like Pepcid or famotidine, Zantac, things like that started, okay? Diarrhea, like I said, if they are having acute diarrhea, that's less than 2 weeks. Chronic diarrhea is longer than 2 weeks. That's usually more inflammatory or an allergic response, or they're having malabsorption signs, okay? Infectious causes can be caused from viral, bacterial, or parasitic infections. That's usually what causes gastroenteritis. And remember, gastroenteritis is the inflammation of the stomach and the intestines. Okay. And I said earlier, because they're eliminating basics, so more alkaline stuff, and they're keep holding on to the acid because they're getting rid of the bicarbonate through their stools, they're going to be acidotic. Constipation, so this is difficulty or infrequent defecation or passage of hard, large, dry fecal material. So there may be periods where they're having diarrhea, or they might be having encapresis, which means fecal soiling. And that is because they're so packed full of stool. The only thing that can get around is the liquid stool, or they're so full that they're having accidents. Okay. Might be a dietary thing, might be a cultural thing, might be social anxiety. They don't want to, you know, have a bowel movement at school, so they hold their poop all day at school. So they're going to be tending to be more constipated. Okay. Making sure that they're drinking plenty of water and staying hydrated. Using laxatives or enemas, so things like X-Lax or an enema daily is very much discouraged. So it needs to be managed more with dietary implementations like eliminating dairy, and sometimes gluten can cause, if they have a little bit of a gluten sensitivity, can cause constipation. Okay. Fluid and electrolyte imbalances. This is most common at kids 2 and younger because their surface area requires or loses more water through the skin than through the kidneys. Okay, so their metabolic rate, their heat production, those are also 2 to 3 times greater in infants per their body weight. So they're more at risk for fluid and electrolyte imbalances as well. Okay. So monitoring for dehydration. So you're going to see increased respirations and increased heart rate a lot of times in these kids before you start to see, you know, like blood pressure changes. Okay. Dehydration. There's different forms of dehydration. So isotonic dehydration, which is equal amounts of fluids and electrolytes are lost. Hypotonic dehydration is where more electrolytes than fluid are lost. And hypertonic dehydration is when more fluids versus electrolytes are lost. So there's each different forms, and you have to look at those as you're giving these kids fluids. Okay. So that Quinny, when you asked about, like, do you usually use the NS and things? So it kind of depends on which category they're falling in. Because if they're falling in hypertonic, where they're losing more electrolytes than fluids, they might need more sodium and more potassium. Okay. Okay, I'm gonna stop here. Does anyone have any questions, concerns, comments? No? Sorry we didn't get to the cahoots.